This is Live Well Talk on Multi-System Inflammatory Syndrome in Children, Part 2. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. Returning today to the studio is Dr. Dilli Bhurtel to follow up on Multi-System Inflammatory Syndrome in Children and to also give his perspective of the condition from a pediatric cardiologist. Welcome back.
Thank you. Thank you for having me again.
So the last time we met, the name was changing.
Yes.
Now we've settled on this MIS-C, Multi-System Inflammatory Syndrome of Children. Tell us, have we had more cases here at St. Luke's?
So we've not had any new cases at St. Luke's, and now as this has been well recognized and almost every state have been already reporting, and lots of case studies have been published, so we have more data now than what we were discussing almost 3 weeks back.
One of your colleagues, Dr. O'Connor, mentioned, who's a pediatric hospitalist, mentioned that it can go up into the 20s.
Yes.
What have you heard of that as well?
Yes, we've heard about that. So there are colleagues in New York, the East Coast, who had the major series, large series of cases, and they have mentioned about these young adults are having the similar findings, like having involvement of the multi-system inflammatory, and they were not typically presenting as like what the primary COVID illness. So we've been getting them, and they're responding to IVIG, the way that we're treating MIS-C. So that also confirms. The unusual thing about the MIS-C is, like, apart from the primary COVID, is the initial diagnosis of like you're getting these abdominal symptoms and the cardiac involvement, like hypovolemic or sometimes distributic shock. That's the presentation. And since we last talk about this, we had another kid here, but we didn't really confirm this as the PCR was positive, but behaved almost like MIS-C, responded to treatment, and there are multiple other comorbidities, so we didn't label it as, but he did respond to the treatment that we did.
And the treatment's still IVIG?
Yes, that's like we're using as IVIG as a first-line treatment, and in some cases we're adding the steroids, and depending on risk groups,
Yeah, for a while, we had a hard time getting IVIG. There had been a shortage, and it's still not plentiful, but not like it was. And this is prior to COVID. We significant shortage, but so that's reassuring that we do have the supplies that we have. Have you heard any case reports of any sort of sequelae or long-term side effects?
So we have not heard. People.
I know it's too soon, but
it's too soon. But there have been lots of, as you've heard about primary COVID and neurological outcomes, right? So that's our worry is that, but we've not really heard. It's really too soon to know about that neurological outcomes. And apparently, the cardiac involvement, myocarditis, they have a acute involvement and they resolve. And we are postulating from other acute myocarditis that if they resolve, the chances of scarring and long-term cardiomyopathy is less. So we're hoping that is the acute phenomenon, and that gets better with the initial treatment. We don't know much about it.
Just for my own knowledge, do children get viral cardiomyopathies like adults do? Same sort of
they do, yeah.
Phenomenon? Okay.
Yes, they do. And interestingly, the viral myocarditis or cardiomyopathy we do see, and they respond to treatment, and rarely that we see any chronic sequelae from that,
Yeah. In adults, we treat them, but we always rule out multivessel coronary artery disease just because it could sublimely present the same way. You don't have to do that in children.
No, we don't have to do that in children. And the baseline in children that we can see those two common arteries, 3 vessels, left anterior and left and right main coronary, easily we can see through the echocardiogram. And we assume that if those proximal vessels are good, that there is no distal involvement. That's the assumption. That's how
really? I didn't know that. So in children, you can actually see those coronaries
vessels pretty well in the proximal course of them.
Huh.
So that's why, we don't do the fancy invasive test, like the cardiac.
Right, yeah.
We don't do those.
That's a nice pearl to know. At what age do they lose that where you can't see that?
That depends on, sometimes, even 13, 14-year-old we could see, and if depending on the body habitus, and the lungs, and that sometimes is very either extreme, if you are very thin, it's difficult after adolescence year, or if you are elevated BMI, or if you are overweight, then we can't get the good window to look those coronaries.
Right.
So I've had to do the CT angio just to look for anatomy in like 8 or 9-year-old, which is very unusual.
Right.
For us, like 14, 15-year-old, we do see the proximal coronaries pretty well.
Back to the inflammatory syndrome we talked about, or this podcast was the impetus for. Was there any predisposition pattern that has been recognized as far as certain children more susceptible?
No, we've not got that, not in any series that is published so far that I'm aware that any kids, who have underlying certain conditions are more prone. We don't have that data. And so far we're postulating from the same Kawasaki type illness, right? Kawasaki disease, and it's the dysregulation of the autoimmune system, hyper response to the post-infectious process. So we are extrapolating that data, and we assume and presume that's the case with MISC as well.
And that's been the issue with the COVID or SARS-2, is that there's so much observational data that is not going to be supported in the long run, that short-term people are trying to make decisions on, including myself. I mean, that's just the nature of a pandemic, I guess, but that has been a tough thing to weed through, hasn't it?
No, absolutely. To extrapolate the data and try to implement and treat your patients from that basis, and it's always that unknown there.
You're right.
And likewise, we've been getting multiple calls right now from our primaries to especially our hospitalist team. They're getting at least 1 to 2 calls, worrying about this condition. Are we missing that? Because we don't have a specific single blood test to say, oh yeah, this is MIS-C or not. I'm glad that our community is aware of this and
absolutely.
picking up the phone. And on the other hand, we're getting multiple calls. I would rather have multiple calls than miss a diagnosis and have a severely ill child, who may or may not make it.
Right.
So,
which is always, as an adult doctor, looking when I have had to go out of my comfort zone, take care of kids, they can present very ill, but then get better within the hour.
Absolutely.
And so it's easy to not take things serious at times with children.
Absolutely. And this has been as this MIS-C has been mostly emphasized on that, how ill they look. Is this kid, if you were not in this MIS-C situation or any other time, would you admit this kid?
Right.
I would really like our primary providers to think that way. Is this kid looking sick enough for you to admit? If you feel your clinical judgment is that, yeah, this kid looks sick, then have a low threshold to get this kid admitted, observe, and do a whole full panel of the lab work. That will help us to guide whether or not it is,
Right.
So, and then if they are a well-looking child, then we can always do daily follow-up and visit. The question comes, which one of these kids that you're going to do the lab work, and how far you do the extensive lab work. And then we end up having some inflammatory markers which are borderline, which you don't know what to make out of that. So we've had a few cases like that as well, since we had this last podcast, that some kids have been investigated and the lab works are a little elevated. We don't have a plausible diagnosis, and we're worried. We're continuously monitoring, and ended up most likely those were viral infections.
Right.
So what we need to bear in mind is common childhood illness. Common childhood illnesses are more common than MIS-C. It's still rare. Since last 3 weeks, we have not had a single another case. So yeah, we may be getting more cases, but we should not be thinking that everything we see is MIS-C.
Right.
Every kid with the fever is not MIS-C. We have certain criteria that CDC has published, and we know a lot already. Yes, they need to have fever, lethargy, abdominal pain, diarrhea symptoms, and any involvement in skin rash. And those are the common pattern that we're noticing on these kids.
And unlike, refresh my memory, do they get thrombocyte, low platelet counts?
They basically borderline low platelet count.
Okay.
And that's basically, we say that, platelet count is 200 to 450, to normal. And they are hovering around 135,
okay,
150.
So not like
low platelet
Henoch, Scholl, purpura, where they obviously have purpura, but also a skin rash, but drop there. Because that has abdominal pain as well, right?
Yes, absolutely. HSP has, abdominal pain. And but the HSP kids are very well-looking kids. And if we are looking into their distribution of the rash, is very typical distribution, lower than the buttock line, and then even extremities would be on the extensor surfaces. So not on the trunk. usually the
Usually
common
trunk sparing.
honoxolone is trunk
And there's a
sparing.
seasonal variant to that, right?
Absolutely.
Like the fall, I think.
Absolutely, yeah.
That's pretty good recall for a
Yeah,
adult
absolutely.
doctor.
You know, I completely forgot about it. It's been 20
So
years.
yeah, see, you know. Well, this is really great information. Again, this was Dr. Dilli Bhurtel from UniPoint Pediatric Cardiology. If you have a topic you'd like to suggest for the COVID-19 pandemic, please shoot us an email at stlukescr@unipoint.org. In the meantime, wash your hands, cover your cough, and confine yourself if you're ill, and practice social distancing.